We are all ready for Chapter 19 now that we've covered a lot of the airway stuff and oxygen administration. Let's talk about some respiratory emergencies. Now we're just going to review respiration, but we're going to really break down breathing difficulty and then the respiratory conditions that we may see in the field. We're going to talk about some of our treatments that may include an inhaler or a nebulizer. So again, back to the anatomy and physiology. Remember, blood goes round and round, air goes in and out. When we breathe, we are actually having a pressure change within the chest itself, in the thorax. So we think about the diaphragm running across the lower part of your rib cage. As the diaphragm contracts, it actually is pushing down into the abdomen. By doing this, it's drawing air in through the mouth and nose and into the lungs, because we've got to try to equal out the pressure, right? When we breathe out, the diaphragm actually relaxes, and this is going to be a passive or resting type of activity, and that is going to then force the air out of our lungs. So that's kind of depicted in these pictures here that you're looking at. Relaxed, you can imagine the diaphragm across the base of the rib cage. Actually, it's a little bit higher, but in actuality, as the diaphragm contracts, you're going to get it pushing down. And again, that's going to cause inspiration, drawing the air into the mouth and nose. Once we are starting to relax, that's called expiration. And expiration, because we are now shrinking the size of the thorax, we are forcing the air out through the only opening that's there, and that's through the pharynx, the mouth and nose. So we've identified inspiration as an active process. We've got muscle contraction going on. We also have some work with the intercostal muscles here, helping to lift the rib cage up and out. The diaphragm lowers, again, ribs are moving up and out, and the air is being pulled in. So the opposite happens when we breathe out. Expiration is passive, meaning everything is starting to relax. As those things start to relax, the chest wall or the thorax gets smaller, and the air is forced out of the lungs with positive pressure. So when you think about breathing, we really need to identify breathing as either good or bad. When we talk about good breathing, that's when we are breathing enough to support life. So for most individuals, you're going to have a respiratory rate anywhere between 12 to maybe 20, 22. If we are below that or above that, we're going to consider that inadequate breathing. So signs of adequate breathing, again, we've got normal mentation. The patient is able to move air when they breathe. They are able to speak pretty normally. They don't have to catch their breath between every couple of words. And when we hook them up to our pulse oximetry, we should get a normal range. Again, you can see that 12 to about 20, 22 breaths per minute for adults is normal. We've got a faster respiratory rate as we are younger. So 18 to 30 breaths per minute for school-age children, 30 to 60 breaths per minute for infants. Usually, along with the rate, we are looking at the rhythm. Is it regular? Could you more or less time their breathing? And then what's the quality? And quality, we're looking at the sound. What do we hear? Is there anything that makes us suspicious for an airway obstruction or some type of disease state? So if adequate breathing supports life, inadequate breathing, as we said, is not going to support life. So again, we may have a rate that's too fast or too slow. It might be irregular. It may cause the patient not to be able to speak, and they may have a silent chest. When we say silent chest, when you listen or auscultate lung fields, you really don't hear anything. and that means there's no air movement. When we say inadequate breathing, what's the patient going to look like? Well, they're going to potentially have agonal respirations. That's very irregular or sporadic. There might be some deep breaths and then some shallow breaths. Again, irregular rhythm. You're going to have a low pulse oximetry reading most likely. Diminished or absent lung sounds. Again, what are we hearing when we auscultate? And poor tidal volume. How much are they actually breathing in with each breath? If they're very shallow, that's poor tidal volume. We should be able to see chest rise and fall. All right, talking about kids here for a sec. Kids' airways are different, and we've said that before. Understand that they are smaller and they can become obstructed more easily. They do have larger tongues, and this can be one of the causes for that obstruction, but they also have smaller, softer, and more flexible tracheas. So think about the positioning of their head. If you're opening their airway, remember we cannot hyperextend their head, and for those younger infants, we may need to actually put some padding behind their shoulder blades so that we can make their ear level with that substernal notch. Children's airways, that trachea and the cricoid cartilage is less developed, and any type of neck injury has the potential to obstruct the airway as well. Kids have a high dependence on diaphragm respiration, and when kids struggle, we're going to see this with their accessory muscles and nasal flaring and some other signs that we're going to talk about. As I said, here we are, we're going to talk about this inadequate breathing for these younger children and infants. We may see nasal flaring. Now, nasal flaring is where the nostrils kind of flare out and in again with breathing. They flare out in order to draw more air into them. Remember, younger infants are obligate nose breathers. We may also hear grunting as they are trying to suck more air in. You may hear this sound kind of coming from the back of the throat. Seesaw breathing is where we've got a seesaw motion between the abdomen and the chest. This is a very poor sign. So if we're seeing this seesaw activity, and believe me, in really bad infants and younger children, you can see this even with their clothing or a blanket on. Retractions, now we have to be able to remove clothing and anything covering the chest. We want to identify retractions if they are there, because this again is a sign of inadequate breathing. The intercostal muscles between the ribs, okay, these are going to be activated or contracting with each breath, and you're going to see that extra pull from those intercostal muscles. You may also see a tugging or pulling on the subclavicular muscles and up near the clavicle. You may see some of that muscle interaction really trying to pull open the chest so that we can draw more air in for the patient. Okay, so we've identified it. What are we going to do about it? If we have inadequate breathing, we need to do something, some intervention. You're going to base that intervention on the whole picture of the patient, not just the breathing, but we have that pocket face mask, which we may be able to use. We have 2 rescuer bag valve masks, and again, that bag is going to be connected to oxygen, so we're going to be supplying the patient with a higher concentration. Also, our 1 rescuer bag valve mask can be used, and again, have that increased oxygen concentration. Okay, so what do we do now that we've identified inadequate breathing? Well, inadequate breathing is likely going to require some artificial ventilation. Again, mouth to mask or the bag valve mask. And with either of these, we're going to be looking for rise and fall of the chest. Adequate artificial ventilation rates. AHA, or your CPR class, talked about a rescue breathing or a respiratory rate of a breath every 6 seconds, and that's going to be 10 breaths per minute. 10 to 12 breaths per minute is appropriate for adults. Now, we still do 6 to 8 usually breaths per minute for kids, and you can see here adequate ventilation rates should be between 12 and 20 breaths per minute. Remember, the younger they are, the faster their normal respiratory pattern is. We've talked about hypoperfusion before and signs of shock. So think about it. If the patient is not getting the oxygen into their body, they have inadequate breathing, we're likely to see an increased pulse rate. So even with our artificial ventilations, if we are not providing those fast enough, we're going to see that increased heart rate as the body is trying to compensate and get circulation increased in order to move that oxygen as quickly as possible. Decreased pulse rates can indicate that your artificial ventilations are inadequate, but this usually occurs a little bit later. Once we've tried to compensate and we can no longer keep up with that, our body starts to fail. Especially in kids, we will see a drop in their heart rate, and this is a very ominous sign. So, how are you going to recognize the progression from adequate to inadequate breathing? Think about someone who is sitting there talking to you and all of a sudden they begin to have difficulties. Identifying those signs of inadequate breathing are going to be important. The faster you identify them and the faster you intervene, the better outcome your patient is likely to have. The easier it's going to be to get them to return to normal. Let's face it, if you wait for them to stop breathing altogether, it's going to be much harder to get them back. Remember, we have signs and symptoms that we're looking for. Signs are the things we see, symptoms are the things the patient tells us. When we're talking about breathing difficulty, understand that the patient's subjective perception is important. If they feel that it's hard to breathe, it's hard to take a deep breath, they feel they have to work at it, that's not a good sign. The amount of distress felt may or may not reflect what you actually see or the severity of the condition, but we do have to take their word into consideration. So we're going to talk a little bit about CPAP. And CPAP is continuous positive airway pressure. This is going to be utilized in some of our patients. It is an EMT skill. But if you look at this guy, he's kind of leaning forward in that what we call tripod position. His skin color is a little pale or even ashen. He doesn't look so good. So we need to intervene. We want to identify our OPQRST and all of our history taking information so that we have a better idea of what the cause of this is. When we talk about onset, when did the difficulty breathing begin? Provocation, what were you doing when it came on? What makes it worse? What makes it better? Quality, is there a cough? Are you bringing anything up with the cough? What does it look like? Is there blood in the sputum? Also, we talk to the patient about quality and identifying the amount of air that's moving in and out of the lungs. Again, a normal breath versus shallow breathing. Radiation, pain or discomfort anywhere else? Does it spread? When you take a deep breath, do you feel it move? Don't forget that subjective scale of 1 to 10 for severity. We use this a lot of times for pain, but we can use it for breathing too. How troubled do you feel your breathing is? How significant is your inadequate breathing? And then time, how long has this been going on? Has it been going on for a day or an hour? Part of our breathing assessment, again, is altered mental status. We're looking at a potential anatomy change in patients with COPD. We call this a barrel chest. And most of us have an AP or anterior to posterior distance that is shorter than our left to right, okay? In a barrel-chested individual, the rib cage has now kind of created a circle instead of an oval. And that is to allow for further expansion of the lungs because there's air trapping going on with COPD. We're going to talk about COPD in a little bit more detail later. Patient's position, are they tripoding? Are they sitting up? Are they leaning forward? Most patients that are having breathing difficulty are not going to be laying down. Can we identify an increased work of breathing? And work of breathing is us looking at the signs of the patient telling me that they are truly having trouble. That's going to include your retractions, your accessory muscle use, your nasal flaring, pursed lip breathing, which is where the exhalation phase becomes active. It's usually passive, right? But it becomes active because of disease states like COPD. And then the number of words a patient can say without stopping. Most of us can say a sentence or even two before we have to take another breath. However, patients who are feeling short of breath or who have an increased work of breathing may have what we call 2- and 3-word dyspnea. So they say 1 or 2, 3 words at a time and they have to take another breath. Again, from the objective point of view, what do we see? The signs. We've got pale, cyanotic, or flushed skin. The patient may have some edema, particularly in the sacral area or kind of at the tailbone or in the feet and ankles. Their pulse oximetry reading is usually going to be less than 95% on our pulse oximeter. Again, all of these things are things we're going to look for, but we need to kind of take them all together in order to determine if this is truly a breathing difficulty situation. Your book has a pretty good table on page 526, and there you can see adequate breathing and inadequate breathing or no breathing. It's going to show you what those signs and symptoms are that you're likely to see, but just breaking them down separately. And then it's going to talk there too about the interventions that you may be able to do. The picture that you're seeing now is on page 530 of your textbook. I know it's difficult to read on the slides here, but you can see it closer in your textbook. It's just identifying again those signs of inadequate breathing or signs of difficulty breathing that we talked about. Okay, when we talk about noisy breathing, we may also call this adventitious sounds or abnormal sounds. Wheezing is one of those. Sometimes you can hear wheezing without a stethoscope. We call that audible wheezing. Sometimes you need a stethoscope. Wheezing may be inspiratory or expiratory, or it could be occurring with both. Gurgling is a sound that you may hear. Snoring many times is an obstruction with the tongue in the back of the throat. That means we just need to manipulate that head and neck area to open the airway. Stridor is a sound that we hear when we have soft tissue swelling or obstruction in the upper airway. And coughing can also be a sign of some breathing difficulty. Auscultating lung sounds is listening with your stethoscope. Now we have a process to do this so that we move from one side to the other side and then down and then back across. So you can start in, the top right corner of their chest, move to the left upper corner, then down to the left lower corner, and then over to the right lower corner. We're going to do that on the posterior aspect as well. You can see this patient has a non-rebreather mask on. The reservoir bag is filled with air, which is a good thing, right? And this medic is listening or auscultating those lung sounds on the patient's back. Now I'll tell you, we encourage you to listen on the chest as well, but many times you can hear it better through the back. So with auscultating, there are normal lung sounds, and normal lung sounds are just air moving through the bronchioles. I'm going to play a sound clip for you and identify all of these sounds that you might hear, including some of those normal sounds. But abnormal sounds may include wheezing. Wheezing is a high-pitched sound usually. It's created by air moving through the narrowed passages. If you think about a whistle, you're narrowing your lips and you're blowing so that air is trying to be forced through a small opening. In the lungs, this happens with the bronchioles, and the bronchioles constrict and we get this kind of sing-song wheezing type noise. Now again, this can be on inspiration, expiration, or both. Crackles can be fine or coarse. A lot of times this is kind of a bubbling sound that you will hear. It's most often heard on inspiration, and it means that there's fluid in the alveoli or near the opening of the alveoli, and we can hear that. I tell people that crackles kind of sounds like if you rub your hair together, for those that have long enough hair. Otherwise, it kind of sounds like a snap, crackle, pop, a fine crackling sound. Now, rhonchi is usually a lower pitch sound. It may resemble snoring or rattling. You're going to hear this as you auscultate the chest. It is caused from thicker mucus or secretions in the bronchioles or the larger airways. And when you hear rhonchi, it's going to sound much more coarse. Rhonchi can sometimes be cleared or moved even if you can get the patient to have a forceful cough. Stridor is a high-pitched upper airway sound. This means we've got partial obstruction up in the trachea or the larynx. This may be caused by soft tissue swelling from croup, from anaphylaxis, or other types of inflammation. I'm going to try to play some sounds for you to hear those lung sounds a little bit better. You can picture then what you're supposed to identify.
Hey everyone, welcome to our video on lung sounds. This is a collection of lung sounds that we have in the library at our website, emtprep.com. We are excited to offer these to you, and we hope you enjoy.
This is a bronchial breath sound. You're listening over the larger bronchus, and you can hear that air move in and out. This sound is your coarse crackles, so it sounds a little more rough, maybe a little bit thicker, but not quite rhonchi. This is fine crackles. Again, think of thinner mucus or fluid like blowing bubbles in your milk. Remember I said diminished breath sounds. We don't hear as much air moving in and out of the lungs. Expiratory wheezing, you can hear the air breathe in, and then you hear that sing-song kind of melody wheeze as they breathe out. A pleural rub is when we get inflammation between the two linings of the lung. So when we get that inflammation, the fluid between the layers, the membranes, do not slide over each other as easily, and you get this rubbing sound. Kind of sounds like a cat purring when you're listening. Sorry, this is rhonchi. Rhonchi is that thicker mucus in the bronchioles. Again, if they cough, it might clear. Remember, stridor is that upper airway obstruction. If they sound this bad, I'd be worried because you've got inspiratory and expiratory stridor. And vesicular breath sounds are, again, one of the normal breath sounds that you might hear, depending on where you're auscultating. So again, those sounds that you heard were through a YouTube channel called EMT Prep. They do a pretty good job breaking down some other things if you're looking for another resource to kind of find some information to help you study. But as we move on here, we are going to also evaluate the vital sign changes that may occur. Remember, we're not just looking at the breathing, but we've got to take into consideration the whole picture here. So what is the patient's heart rate doing? Is it increased or decreased? Do we have a change in their rate of breathing or their rhythm? And do they have any issues with their blood pressure, hypo or hypertension? And we're looking for the adequate ventilations. So if breathing is inadequate, then we must provide artificial ventilations. Think about the tools that you have. Adequate breathing means that we can use some of our other airway adjuncts, and this may be our nasal cannula, our non-rebreather. Think about how high or low the settings can be on your flow meter for your oxygen. Think about how severe the situation is with your patient, and do we need to deliver a higher concentration of oxygen or just a little bit. This is your flow meter. Remember, you can adjust that based off the oxygen delivery device you're using. Here we're setting it at 15 liters, which tells me we've either got it hooked up to an Ambu bag or we've got it hooked up to a non-rebreather. So what else can we do for our patient? Keep in mind that this patient may be very anxious. They may not know exactly what's going on. They don't feel good. We need to put them in a position of comfort. And I usually say mental and physical rest. So try to reassure them. Let them sit up on the cot as best you can position them so that their breathing is as easy as it can get. We may be able to administer or assist them with administration of an inhaler. These are typically what we call rescue inhalers, and it has the medication of albuterol in them. The brand name may be Proventil on the little canister. We can also use our CPAP, or continuous positive airway pressure. This is going to be another one of those delivery devices that we will show you how to hook up and place on a patient. So continuous positive airway pressure is a non-invasive positive pressure ventilation. This is continuous increased flowing of oxygen into a mask that we strap on the patient's head, literally. So with that, I like to tell people it's kind of like you putting your head out of your car window while you're driving 70 miles an hour down the interstate. You're going to have that constant flow of air with pressure right in your face. Now, why do we use this? Because if we have fluid collecting in the alveoli, the CPAP can assist with kind of pushing some of that fluid out, and it prevents the alveoli from collapsing. We know if it collapses, there's not going to be any air circulating through there, which means we're not going to be offloading the oxygen, onloading the oxygen, offloading the carbon dioxide as we should. So again, if we are thinking that the patient might have some pulmonary edema, we are hearing some crackles, then CPAP may be an intervention we think about. Again, those common uses for CPAP are going to be pulmonary edema, drowning, where we have some fluid in the lungs. We may also use it in asthma or COPD. Remember, sometimes we need to go with something a little more conservative and work our way up. That's perfectly okay. But if we've got a patient in respiratory failure in general, we may be able to use our CPAP. So a couple of things to remember with CPAP here, we are taking a mask that is hooked up to our oxygen, and we are literally strapping it on the patient's face. The patient must be breathing on their own, and they must have adequate rate of breathing. These patients cannot be altered. They cannot lay down. They have to sit up with CPAP. And hypotension or shock is going to be a big red flag. Again, we do not want to hook these patients up to CPAP. We need to try some other interventions, and that may be some manual ventilations if the patient is truly in distress. So CPAP has to be applied and it has to be left on. We cannot take it off. It can cause very dry mouth, and so some patients don't tolerate it. It can sometimes make patients feel claustrophobic, so they may not tolerate it. But again, things to think about that should stop us from using CPAP would also include nausea and vomiting. We do not want the patient to vomit into this mask, and we can't keep taking it off. Any chest trauma, shock, we mentioned kind of before, upper GI bleeding or recent gastric surgery. Because CPAP is a continuous pressure, it may blow some of that air into the stomach. And so if we already have some GI issues, we don't want to make that worse. And then any condition that would prevent a good seal. This seal is going to be maintained throughout the course of this CPAP treatment. And I'm telling you, once we put it on, it's likely it's going to stay on all the way to the hospital and even once we get there. So we need to have a good seal. Sometimes anatomy may cause issues with that, or especially if a patient doesn't have any teeth, we can't get that good seal. Facial hair can also be an issue. There are some side effects with the interventions that we do, and we need to be on the lookout for them. Hypotension is one. When we use CPAP, we might see a drop in their blood pressure, which is not a good thing, especially if the patient is already showing us some signs of distress. If the CPAP, the pressure is too high, a pneumothorax can occur. This can also occur if the lung tissue is very delicate. Again, this is a side effect and not something that you necessarily would have known is absolutely going to happen with the patient. There is a risk of aspiration, again, why we do not want to use CPAP if the patient is nauseous and at a risk to vomit. Drying of the corneas because of this high pressure, again, with the sinuses and the location of the mask, we want to make sure that the mask is properly fitting and that the patient tolerates it well. CPAP pressure can be adjusted, and so we usually like to start low and find what works best for the patient, giving us the effect that we want and that the patient can tolerate. Be sure that you explain this whole procedure prior to putting on the mask. Again, if the patient tells you right away they have issues with claustrophobia, this may not be a treatment that they will tolerate. Remember this guy from a few slides ago? Yeah, he still looks pretty bad, so she is going to be hooking the patient up to CPAP. You can see it is a mask, and you can see kind of dangling off of there is some elastic or rubber straps that are going to go around the patient's head, securing the mask in place. Once we hook the patient up to CPAP, we've got to continually reassess their status. This includes their mental status, their vital signs, and how are they feeling? Do they feel the dyspnea or that shortness of breath is getting better? We also know that if we start low, we've got some room to work. So if we aren't seeing the changes that we want to see, or if we're seeing changes we don't want to see, we may need to bump up that CPAP pressure. This is a good picture showing the patient with that CPAP device on. You can see the medic is checking vital signs, which is great. The patient is still sitting upright, breathing on their own. The mask is very tight fitting. Again, it has to create an airtight seal so there's no leaking of air or leaking of that pressure. The straps are going to go all the way around the patient's head, and there are typically 2 straps on the left and 2 straps on the right that's secured to the mask. Now, if the patient deteriorates, if the patient is no longer breathing adequately on their own, we've got to get the CPAP off. We may need to begin artificial ventilation with our bag valve mask. It appears our gentleman has gone unresponsive, so you can see the 2 medics. They have removed the CPAP and they have the bag valve mask they're going to begin to use. I'm going to tell you, if you're going to use a bag valve mask, this is going to be a really difficult position to try to open that airway and do it properly. So let's get the patient on the floor or on the cot quickly so that we have proper angulation and we're able to open that airway without too much difficulty. COPD is probably a term that you've heard before. It stands for chronic obstructive pulmonary disease. This is a pretty broad class of disease states that we kind of cover with COPD. Emphysema is one, chronic bronchitis is one, and there are other respiratory illnesses that kind of fall into this category. The majority of COPD patients have a history of smoking. Some may still be smoking even with this diagnosis. Don't be surprised even if you see people on home oxygen smoking with their oxygen on. It's not safe practice, but it is done by some. So your chronic bronchitis, when we talk about COPD, this version of COPD is where we get bronchial lining inflammation. So we've got inflammation, irritation in the bronchioles. This makes the body increase the mucus production in the bronchioles themselves. And then the cells in the bronchioles that usually would clear away the mucus, they're unable to do so. So here you're getting the mucus and it's really not moving anywhere because the cells within the lungs have been damaged, again, many times from smoking. Here you can see an image, and this image is in your textbook on page 539. You can see the normal alveolar sacs there on the far left. In the center, you see chronic bronchitis where we've got mucus production, and some of that mucus is blocking the opening of the alveoli for that air to come in. When we talk about emphysema, emphysema is more of an air trapping where we have air that's stuck in the alveoli. It's not being exhaled, and therefore it pushes out. So the alveoli all kind of merge. This decreases our surface area, and again, we have less ability for the body to actually go through respiration. So here's the slide on emphysema. Again, another type of COPD. The alveoli walls are breaking down and the surface area is decreased. The lungs begin to lose their elasticity, and the air is stuck or trapped within those alveoli. So it reduces the effectiveness of normal breathing. Asthma is another disease state that you may run into. This is not COPD. When we talk COPD, we're talking chronic bronchitis and emphysema. Asthma is its own creature, and asthma is usually diagnosed in childhood. Many patients will grow out of it as they get older, but some will not. It is more of a chronic disease, and it has episodic exacerbations. So what that means is you don't feel asthma all the time like you do with COPD, but when you do something that triggers that asthmatic response, you start to have the wheezing, you start to have the shortness of breath. So during an attack, the bronchioles narrow, or we get what we call bronchoconstriction, and mucus is overproduced. So you've not only got narrowing, but you've got mucus blocking the airways. So this is going to make it difficult for the patient to get air in or out. As I said, the air is going to be restricted in or out, typically one direction. Exhalation, where we have expanding lungs, this exerts that outward pull and increases the diameter of the airway. The exhalation is the opposite, and the air becomes trapped. Edema is excess fluid, and we get edema or swelling at the ankles and different parts of the body. We can also get edema in the lungs, so we call this pulmonary edema. It is an accumulation of fluid in the alveoli, and this causes an interruption of the transfer of gases. So patients with congestive heart failure many times experience pulmonary edema. Pulmonary edema is one of those conditions where our CPAP may help us. So you have a buildup of pressure in the pulmonary capillaries. Fluid crosses that barrier and accumulates, and therefore it does not allow for gas exchange, and the patient begins to experience dyspnea or shortness of breath. With pulmonary edema, there are some different signs and symptoms that you may want to kind of look for. One of them is dyspnea. One is anxiety. The patient may feel like they're drowning. Pale, sweaty skin because they're working harder. Tachycardia. The heart is trying to compensate, and so it's trying to pump faster to circulate what oxygen is there. Hypertension. So we get a little bit of vasoconstriction, which causes an increase in the blood pressure, again, trying to get that blood where it needs to go so we can get more oxygen to the organs of the body. Respirations are usually rapid and labored, so the patient is working. We also have a low O2 saturation with our pulse ox. Now with pulmonary edema, again, you may be able to hear gurgling or crackles when you listen to their lung sounds. Have the patient take a breath, and if you think you hear something, have them take another. It's okay. Patient may cough, and when they cough, they may have some sputum. In pulmonary edema, it's usually a white, kind of frothy sputum, but there may be some pink tinge or even blood streaking in it. Don't be surprised and don't panic. These patients usually get a higher concentration of oxygen, and if their breathing is inadequate, then we need to intervene, likely with a bag valve mask. However, if the patient is breathing on their own and they can tolerate it, let's try our CPAP and see if the CPAP can help push that fluid back out of the lungs. One of the things to keep in mind, if possible, is this is edema, and edema flows with gravity. It's going to go wherever gravity is pulling it. So if we dangle the patient's legs off the side of the cot or in a dependent position, then hopefully gravity will help to pull some of that fluid out of the lungs. And yep, they're probably going to have some pedal edema, but we'd rather have the fluid there than in their lungs. So what do you think? We've talked about a couple different respiratory issues. Could a patient have more than one? Yes, absolutely. Think about a patient who may have COPD and maybe pulmonary edema at the same time. Pulmonary edema can be caused from heart failure, so we've not only got issues with the lungs, we've got issues with the heart that are causing more lung problems. Winter months are usually where we see the most cases of pneumonia, but pneumonia can affect one or both lungs. Pneumonia can be from bacteria, viruses, or fungi. So bacteria can be treated with an antibiotic. Viruses cannot. Fungi needs its own type of medical treatment. Results from inhalation of certain microbes, and those microbes then grow in the lungs and cause inflammation. The patient may complain of some dyspnea. This may be with exertion or it may be at rest. Coughing. Many times they will have a fever or chills, and they may have some chest pain with breathing. Worse with inhalation. Many of them will describe it as a sharp pain, and again, with inhalation. Other things we may identify are headache, pale sweaty skin, they're more fatigued, tired, and maybe even some confusion depending on what our pulse ox is and how it's affecting their mental status. Well, I mentioned that we've got bacterial, viral, and fungal types of pneumonia. So what are we going to be doing for these patients? What we do is called supportive care. We are going to assess the patient. We're going to try to provide them some reassurance. And if we identify inadequate breathing, we need to try to fix it. We want the patient to stay well enough to arrive at the hospital and then get the appropriate treatment. If the patient's hypoxic, we can give some supplemental oxygen. If the patient needs ventilatory support, we may have to use our bag valve mask. Some EMS systems will allow their medics to use CPAP on these patients, so check with your protocols. I think you're going to need to really base that off of, your patient and how they look to you. And in some cases, again, may need some artificial ventilations. So spontaneous pneumothorax is an interesting thing that can happen. This is where we get a lung that collapses. This is due to no injury or any other obvious cause. We see this sometimes in people who are tall and thin with a condition called Marfan syndrome. It's the same disease that Abraham Lincoln had, but these spontaneous pneumothoraxes, they just kind of happen, and we also see this at risk in patients who have COPD or a history of smoking, where we've got damage to the lung tissue from a chronic type of condition or activity. Patients with spontaneous pneumothorax are going to have some different complaints than your pneumonia patient. These patients are going to say they have a sharp, sudden onset of chest pain. They will have sudden onset of shortness of breath. They will become more fatigued and have more dyspnea with activity. We may see a low oxygen saturation, pale or even cyanotic skin. It's likely that we're going to see an increase in the heart rate and an increase in the respiratory rate as the body is trying to compensate. When we auscultate lung sounds, we may hear decreased or absent lung sounds on one side. Again, remember, we listen to the right and then the left and then the lower left and then the lower right. So we're comparing the right and left uppers and we're comparing the right and left lowers. So listen for that decreased sound to be on one side or the other. The patient may also have signs of hypotension as this continues, or JVD, which is jugular vein distension. Jugular vein distension is pictured on page 541 of your textbook. If you assess a patient and you feel that they have a spontaneous pneumothorax, this patient needs help. They can develop significant respiratory distress if we don't get something going. So call for ALS Intercept. Administer oxygen. We do not use CPAP because there's already a hole in the lung. And if we apply CPAP, then that air is actually going to be trapped inside the chest cavity and not in the lung itself. So no CPAP. Transport the patient as quickly as we can. Many times when a patient has a pneumothorax, again, this one's spontaneous, they may need a chest tube, and the chest tube is done in the emergency department where they put in a hole in the chest wall and hook it up to suction so that the lung can hopefully heal and re-inflate. Now, an embolism is a blockage in the circulatory system. This can occur in the lungs, in which we call it a pulmonary emboli. This is where we block the blood supply to the lungs. Now, this is so the lung tissue itself is not getting oxygen. If the lung tissue itself is not getting oxygen, it's not going to function. So many patients start off with what we call a DVT, or deep vein thrombosis. This is a blood clot that develops, a thrombus that develops behind the knee, and it breaks off and then becomes lodged in pulmonary circulation. Patients can develop DVTs for various reasons. If they have periods of inactivity, they're very sedentary, maybe a long car ride where they don't get up and stretch their legs, you can get these thrombuses to form. Patients who have cancer or who have immobilization of a limb due to a cast. With a pulmonary embolism, the patients again are going to have that sharp pleuritic chest pain that starts kind of out of nowhere, right? It's a sudden onset. They have sudden onset of shortness of breath. They're likely going to be very anxious because they feel like they can't breathe, and they can't. There may be some coughing, some increase in heart rate and increase in respiratory rate are common. Lightheadedness or dizziness can occur. Again, we are potentially going to alter their mental status because of lack of oxygen. There may be pain and swelling in one or both legs. That may tell me that, again, this was a DVT, and the DVT causes that pain and swelling in the lower extremities particularly. Hypotension can occur and even cardiac arrest if we don't do something. Again, for us, it's going to be that supportive care. We may need to give them some oxygen, but we've got to get them to a higher level of care as quickly as we can. These patients are likely going to have a CT done, and that CT will show the pulmonary embolism, and then they will decide on how they're going to attack it. Most of the time, they are given medications to help dissolve the clot to reestablish circulation. So if you recall, the epiglottis is that little flap kind of that covers the trachea so that you can't get food or liquids and things into the lungs. But epiglottitis is where we actually have an infection of the epiglottis. In severe cases, this can cause swelling to the surrounding tissue, and it can cause an airway obstruction. This is also painful, so the patient is likely going to complain of a sore throat. They may have pain with swallowing, or maybe they refuse to swallow. Children especially, if they are drooling to the point that they are not swallowing, it's a big red flag for potential epiglottitis. Patients are likely going to be in the tripod position. They appear sick. They look like they don't feel good. You may hear a muffled voice if they try to speak because of all of that swelling back in the pharynx area. They may have a fever. You may also hear stridor with their breathing. We need to provide reassurance not only for the patient, but many times for the parent if this is occurring with a child. Try to keep that patient calm and comfortable. The more that they work themselves up, the more they cry, the harder they cry, it's likely going to irritate this even more and can make that swelling worse. Do not try to look down their throat. If a patient is unwilling to swallow to the point of drooling, I know there's a problem. I don't need to look because I'm not going to be able to do anything about it. And I just need to get the patient some oxygen and get them to the hospital. Croup. Croup is a common illness that we see in the colder winter months and in early spring. This is caused by a group of viruses that will cause inflammation in the larynx, the trachea, and the bronchi. When we get inflammation here, we get swelling. That swelling creates a partial upper airway obstruction. This obstruction restricts and limits the amount of airflow, and so we can hear this stridor with breathing. Patients with croup, because of the swelling, also have a very unique cough. It's very loud and harsh and barky, like a seal. They have a hoarse voice. There may be some difficulty with breathing, and so we need to make sure that these individuals are placed in a position of comfort, usually sitting up. Watch for signs of inadequate breathing. Pale skin, cyanotic skin, altered mental status, those are all signs of hypoxia, and we need to intervene and do something about it. Significant breathing difficulty can occur with croup, so again, they need to be transported if we've identified it as being severe. Now, if the patient's breathing is not adequate, we may need to intervene. Now, I'm not going to be able to shrink the swelling and inflammation that's going on, but I'm going to use my BVM to provide some artificial ventilations, a little bit of force to try to get something down into the lungs. ALS is a great intercept for these patients, and again, getting them to the hospital as quickly as possible, however that may be. Bronchiolitis is a condition that we see in pediatric patients mostly. This is when the smaller airways become inflamed, again from a viral type of infection. Many children will have a condition called RSV, or respiratory syncytial virus, that causes bronchiolitis. These cases usually start out with cold-like symptoms, runny nose, fever, just generally don't feel good, but their condition can progress and they can develop some respiratory distress. This can be passed along in households, especially when you've got multiple children or children who are sick attending preschool, daycare, things of that sort. It can cause significant respiratory distress, and these patients can be very, very sick. Again, this is a virus type of infection, so antibiotics are not really going to help. However, there are other medications that can be given in the emergency department at the hospital that may be beneficial to these patients. So let's get them to the hospital. En route to the hospital, if we need to provide artificial ventilations with a bag valve mask, let's do it. Watch for signs of hypoxia. Provide some supplemental oxygen. If we don't need our BVM, maybe just applying a nasal cannula or a non-rebreather mask would be appropriate. Make sure that you keep any secretions out of the airway. We can use a bulb syringe on those infants. We can use our other suction catheter devices to remove any other secretions from the mouth and nose. And remember, infants are obligate nose breathers, so clearing their nasal passages is going to be really important and may extremely improve the patient's condition. So cystic fibrosis is a genetic disease. This isn't something you're going to pick up or develop at some point in your life. This is genetic and it's passed along from the parents. With genetic testing, many times we know even before the baby is born if they have cystic fibrosis, but the symptoms are usually going to appear in childhood. With cystic fibrosis, you get thick and sticky mucus that is going to accumulate in the lungs, in the digestive system. So with this mucus, we can have blocking of the airways. We can also have blockages of the GI tract. Mucus can cause life-threatening lung infections and digestive problems. So these patients, as soon as they're identified, they're going to begin certain treatments. They're going to be monitored very closely. The parents are going to be able to fill you in on a lot of information regarding these children or these individuals. And these individuals, again, are likely to develop lung infections. So we've got to be on the lookout if we have a history of cystic fibrosis. Again, because of that increased production of mucus, the patient is likely going to have a cough and may cough up that mucus. They're going to be very fatigued because breathing is taking a lot out of them. Frequent lung infections, including pneumonias. Frequent abdominal issues, including abdominal pain and distension. The patient may cough up blood. They may feel nauseated, and they may have weight loss. Patients with cystic fibrosis have ongoing treatment regimens that they're going to follow. It's important to identify what is their baseline, what's normal for the patient, and then how do we move forward from there? Is this severe or is this minor? Do we think there's an infection occurring in the respiratory system? Again, the patient or the caregivers, the parents, are going to be able to provide you with a lot of information. So listen to what they have to say. Viral respiratory infections. Viral respiratory infections are everywhere, and right now we're dealing with coronavirus and all of its different mutations. Upper respiratory infections are very common. They affect more than 17 billion people every year. Some people get very, very ill and can even die from these upper respiratory infections, as we've seen with COVID. Other people are barely symptomatic, if at all, and we've seen that as well. So these upper respiratory infections, again, many of them are viral. They cannot be treated with antibiotics, but the patient may have some severe signs and symptoms. This is usually a progression of symptoms, so we might start with a sore, scratchy throat, runny nose, they don't feel well, they can develop fever and chills, and as that infection continues to worsen, they can develop shortness of breath, they can have a cough, it may be very forceful, and have yellow or greenish sputum production. As I said, viral respiratory infections cannot be treated with antibiotics, but there are other medications that may be provided at the hospital for their treatment. We need to provide supportive care, supplemental oxygen, maybe a bronchodilator if we hear some wheezing. Albuterol is our bronchodilator, and again, that is going to be administered through a nebulizer setup, and you're going to be covering more of that in your pharmacology lecture. Good hygiene is going to be very important. Right now, we are encouraging mask wearing, we're encouraging distancing, we're encouraging good hand washing all of the time. Cover your coughs and sneezes. We always recommend these things to reduce the transmission of any germ, but especially these respiratory type infections. On page 546 of your textbook, you can follow along here with the prescribed inhaler. We usually call these metered dose inhalers because it is a controlled amount of medication that they are getting with each depression of the inhaler cartridge. So this is, again, exactly measured amount of medication. These are prescribed a lot of times for bronchoconstriction. And when we talk about albuterol or the brand name Preventol, this medication is a bronchodilator. So it's going to open up those bronchioles that have kind of constricted. So I'm sure most of you have probably seen an inhaler, but maybe you've never used an inhaler. So with an inhaler, it's important to time the depression of the canister with the inhalation of the patient. So a lot of times we want to make sure that the medication is going to get down into the lungs. It can just sit on the mucous membranes and sit on the tongue if they don't breathe properly with the depression of the canister. So most often we'll have the patient breathe out and then put the inhaler in their mouths. As they breathe in, depress the canister, have them hold their breath for a few seconds, then they can breathe out. Most of the time they're going to get 2 puffs, so wait 30 seconds to a minute and then do it again. Now an inhaler is a medication, so we need to follow our medication rules. So we need to make sure that we are following the 5 rights. We really say 6, but 5 rights include the right patient, the right time, the right medication, the right dose, and the right route. The last of those is the right documentation. So the right patient, we've got the patient, they need it. The right time, they're having trouble breathing, it's the right time. The right medication, look at the canister, see what the medication is that you're going to be administering. With a metered dose inhaler, we know it's the right dose because it's already calculated out. And the right route, this is going to be inhalation. So we understand how to administer that with having the patient breathe in as you depress the canister. Don't forget to document all of this information later because your documentation is extremely important. Check the expiration date and the label on the canister to be sure what you are administering, and understand that the medication inside the canister can settle. So it is important to shake it for a few seconds prior to administering it to the patient. If the patient is alert enough to use their inhaler, let them use it. Many times we'll use a spacer device if the patient has one. This is probably more often used in younger children because if you have difficulty timing the depression of the canister with the inhalation, the medication actually gets trapped within the canister and the patient can actually breathe in and out a couple of times to be sure they get all of the medication. A picture of a spacer is on 546 of your textbook down at the bottom. You can see how the normal handheld inhaler is located on the back side. You have a long chamber and then the other end is where the patient would place their mouth. Here they are reviewing the rights with the patient, and then they will later document. And this is a picture of that spacer. You can see it's called an aero chamber or a spacer. Again, many patients have these if they have difficulty with regulating the inhalation and depressing the canister. All right, those steps that I've already gone over here, administering the inhaler, have the patient exhale, put their lips on the opening, depress the inhaler canister to activate the spray, and have the patient inhale deeply. The patient can hold their breath for a few seconds here, and that allows the medication to stay in the lungs and get absorbed so that they do not just exhale it out. A small volume nebulizer is something that we use sometimes for patients with respiratory issues. This is a device that we're going to hook up to our oxygen, but we're actually going to put a liquid medication into the small canister and then hook it up to our oxygen so it becomes kind of a mist, a vapor, and the patient will breathe that in. So it comes in a small vial. On the vial, we'll say the name of the medication. And again, we're going to empty that little bit of medication into a cup or the small canister that comes with the nebulizer unit. We're going to have to put all of these pieces together and then hook it up to our oxygen. The patient will hold one end in their mouth and they will breathe normally, continuously, as the oxygen is running through the liquid, turning it into a vapor. So this is something they're going to hold in their mouth and continue to breathe in for several minutes. And we've got to be sure that we have our oxygen setting done appropriately, because this should be done at between 6 and 8 liters per minute. If we don't have it fast enough, then the particles are going to be too large and it's not going to get down into the lungs. If we do it too fast, the patient doesn't really breathe that fast, and so you're going to end up wasting a lot of medication and the patient then doesn't receive it. So by doing this type of albuterol administration, we're able to have the patient exposed to the albuterol for a longer period of time. This, again, is helpful if you've got extreme wheezing or bronchoconstriction, that we can get it under control quickly. In your textbook on page 551, they are going to administer a albuterol nebulizer treatment, or handheld nebulizer, we call it. You'll see in picture 3 the small cup that the medic is holding, and he's squeezing the medication from that little plastic vial into the cup. In the picture 4, which is also the picture you see here on your slide, you can see how all of those pieces fit together. So the oxygen plugs into the bottom of that little cup. There's a T that's screwed onto the top of that little cup, and from that plastic T you have a mouthpiece, and then you have a blue corrugated piece, or sometimes it's clear corrugated plastic. But what this does is the corrugated tube there on the end kind of creates a reservoir, so a little bit of the medication will stay in there. When the patient inhales, they will breathe all of that medication down into the lungs, and then they're able to freely exhale. Hang in there. I know that was a long lecture, but moving on to the chapter review now. Respiratory emergencies are common, and we have to do the best we can, many times knowing that we cannot fix the patient, but we have to provide that supportive care to the patient. It's important that you understand the anatomy and physiology that goes along with the respiratory system. It's important that you have good assessment skills and that you're able to critically think what is going to be the best treatment option for each patient. Remember, the cardiac system and the pulmonary system are very closely related, so we may have one causing issues with the other. Be sure that you are identifying the signs and symptoms quickly and intervening as quickly as possible. As we talked before, the body will try to compensate. So initially you might see an increase in respiratory rate. However, as we get tired and our body is starting to run down, the respiratory rate is likely to become slow and shallow. Don't forget to get some information either from the patient or the family or whomever might be present. We need to know if the patient has any pertinent past medical history. Are they on any medications? Our OPQRST and sample history are going to be important in treating these patients. Remember, your cystic fibrosis patient, they're likely to be able to tell you what to do. Keep in mind, we need to assess the whole patient. So we're looking at several different things, including their work of breathing, accessory muscle use, the pulse oximetry reading, lung sounds, and their overall vital signs. We do carry a couple of medications as EMTs that will sometimes help, so make sure that you understand those medications completely. This is kind of part of your ABC with the primary assessment. So we need to identify the patient's ability to breathe. Is it adequate, inadequate, or completely absent? From there, what type of oxygen delivery device or ventilation therapy should we use for this patient? Think about your protocols and your scope of practice. Understand what you can do and what you cannot do. Make sure that as we are looking at the patient, they fit the protocol that we're going to use. As you go through pharmacology, you will find that there are side effects to medications and there are contraindications to medications or reasons why you should absolutely not use it. Make sure that you are familiar with these medications because you do not want to give something to someone and create a worse problem or a new problem. Okay, so what's the patient respiratory rate going to do when they become hypoxic? It's going to increase, right? It's going to increase because the body is saying, hey, we need to get more in because we're obviously not getting enough. What would you expect a patient's pulse rate to do when they get hypoxic? Again, it's going to increase because the body's going to say we need to circulate more blood because the blood is carrying the oxygen, hopefully. And if we do not correct the situation, then the heart rate and the respiratory rate may begin to fall. Think about what you're going to see with the patient. What are the signs that you're going to see if the patient is having inadequate breathing? What is the patient going to tell you? So, would you expect to assist a patient with their inhaler if they have congestive heart failure? Why or why not? Well, we have to look and see what the inhaler is. There are all kinds of different inhalers, but it's unlikely that we would be giving something for congestive heart failure. Typically, the patient will have maintenance inhalers that will help, but we know the albuterol works on bronchoconstriction, and congestive heart failure for the most part is going to be fluid. List some differences between adult and infant or child respiratory systems. Kids' airways are smaller, kids have larger tongues, the trachea cricoid cartilage is not as firm. This leads them to potentially have more complications with their airway and respiratory system. So we've got a patient here. She's 72 years old. She's got some shortness of breath. Her husband notes that she's been confused. Think about that. And you note a respiratory rate of 8. Doesn't sound good. What about some cyanosis to go along with that? As we are kind of talking to the patient and the patient's husband, we find out that she has a history of COPD and congestive heart failure. So what are we going to do for this patient? Well, let's see what's going on. She's only breathing 8 breaths per minute and she's cyanotic. I'm probably going to begin ventilating her with a bag valve mask. She's also altered, which is again a big red flag that she's hypoxic. So the confusion, the rate of her breathing, the cyanosis, the complaint of shortness of breath, along with her history of COPD and CHF, tell me that I've got to do something and ventilation is likely what I need to do. All right, that's it. You can go ahead and look through the rest of the slides. They just talk about the pictures that were in the slideshow. Read your chapter. And if you've got questions, don't be afraid to ask. We're getting into the heavy stuff, the really important stuff, and there's going to be a lot of information thrown at you. So good luck.